Welcome to A Changing Conversation, Delaying the Onset of Type 1 Diabetes. I am Kimber Simmons. I'm a pediatric endocrinologist at the Barbara Davis Center in Aurora, Colorado.
I'm Jessica Stoughton, pediatric nurse practitioner at the Barbara Davis Center.
After this education session today, we hope that you will have improved confidence and ability to advise clinical colleagues on how to identify and screen people for type 1 diabetes. We hope that you will be able to establish a treatment plan for patients to delay the onset of type 1 diabetes if they are eligible. We would like you to be able to describe other immunotherapeutic approaches that can delay the onset of clinical type 1 diabetes. And finally, we would like you to feel comfortable with taking care of or monitoring patients after they have underwent immunotherapy to delay the onset of type 1 diabetes. We will discuss 3 separate topics. We will talk about the role of screening in the delay for type 1 diabetes. We will then talk about how we can utilize immunotherapies to delay the onset of type 1 diabetes. And last, we will talk about how to care for somebody after they have received a treatment to delay the onset of type 1 diabetes. For the first section, we were going to talk about the role of screening.
The Smiths took their 9-year-old son Jack to their primary care provider for his annual well child check. Jack's cousin was recently diagnosed with type 1 diabetes, and the family wants to know if that means Jack and his siblings are at an increased risk. The family wants to know if they should do anything to make sure that Jack doesn't also have type 1 diabetes.
It's important to remember that type 1 diabetes is an autoimmune disease of the pancreas. Specifically, it is an autoimmune disease of the beta cells in the islet cells of the pancreas, and those cells make insulin. We will talk about the natural history of type 1 diabetes in a moment, but what happens is that autoreactive T cells, the infection-fighting cells in our body, attack and destroy the beta cells, and along with that, there's a lot of inflammation that further damages beta cells. And over time, as these cells are damaged, they no longer can make enough insulin for the body to be able to get the glucose or energy it needs to survive. So type 1 diabetes is complex, and we know that there is a background of genetic risk that puts somebody at risk for development of type 1 diabetes. But we also know that there is not one gene that confers risk. HLA, or human leukocyte antigen, is the gene that confers the most risk for type 1 diabetes, with approximately half of the genetic risk being due to this gene. Other non-HLA genes are also associated with type 1 diabetes risk. There have been many studies looking at the genes and the SNPs within those genes that confer risk. And these have been combined into genetic risk scores. Some of the genes that have been implicated in these scores are the insulin gene and then gene encoding for CTLA4. But we know that there are many genes, and it's a combination that really puts somebody at risk for having an environmental trigger start the cascade to development of type 1 diabetes. We're not sure what that environmental trigger is. There are a lot of studies looking at the impact of viral infections and also if there's an impact of the gut microbiome on the development of type 1 diabetes. So despite not understanding in each person what genes are predisposing them and not understanding exactly what the environmental trigger is, the overall natural history of type 1 diabetes is very well understood. We know that 9 out of 10 people with type 1 diabetes do not have a family history. So again, not completely genetic, as in you pass it down to everybody. But if you do have a family history and you share the same genes, your risk is increased 10 to 15 times compared to someone who does not have a family history. Once the environmental trigger occurs, patients have evidence of this in their bodies with islet autoantibodies, which we will talk about more. But when someone has the presence of 2 or more islet autoantibodies, they have entered into stages of type 1 diabetes. If blood sugars are normal, they have stage 1 type 1 diabetes. As the diabetes progresses and the beta cells are destroyed and less functional, people start to have abnormal blood sugars and then enter stage 2 of type 1 diabetes. During this stage, the patients can continue to be monitored or followed over time by healthcare professionals. But there is also a treatment that we will talk about later that some patients 8 years and older may be eligible for once they are in this stage of diabetes. And then as the beta cells get really stressed and cannot make enough insulin to keep blood sugars normal, a patient enters stage 3 type 1 diabetes and requires insulin therapy.
Why do we screen for type 1 diabetes? We have 3 reasons. We want to reduce the risk for diabetic ketoacidosis. Acute risks of DKA are admission to intensive care unit, risk of cerebral edema, emotional trauma to patient and family, long-term risks of DKA, worsened long-term glycemic control, impacts to memory and cognition, risk for micro and macrovascular complications, treatment to preserve beta cells, reduce risks of severe hypoglycemia and retinopathy, improves hemoglobin A1C, and reduces total daily insulin dose. We could also enroll patients in a clinical prevention research trial.
In order to screen for type 1 diabetes, we measure type 1 diabetes associated antibodies or islet autoantibodies. There are 4 major biochemical antibodies, and as we discussed earlier, these antibodies are made in response to pieces of protein from the beta cell and also from insulin itself. So you can see on the right here that there is a picture of the beta cell, and that the pieces of protein from the beta cell that antibodies are made towards are GAD65, IA2, zinc transporter 8, and then insulin. When we're trying to decide who to screen for type 1 diabetes, the first step is to increase your pretest probability by picking a population that is at the highest risk. First-degree family members are at a higher risk than the general population, somewhere between a 10 to 15 times higher risk than the general population. And although 90% of people who develop type 1 diabetes do not have a family history, most of these patients probably have a personal or family history of autoimmune disease. There has been a lot of work trying to determine when is the best time to screen for type 1 diabetes, and the best information we have thus far is looking at large longitudinal birth cohorts that have measured islet autoantibodies over time. If you look at the graph on the right, you can see that antibodies peak in kids who are at risk for type 1 diabetes and eventually develop type 1 diabetes between the age of 9 months and 2 years, and that there's a predominance at a young age of insulin autoantibody. There's another peak right around the time of puberty, a little bit earlier, where you see GAD antibody increase along with another increase in insulin autoantibody. IA2A usually does not occur alone, so it's a highly sensitive and specific marker for type 1 diabetes progression and is the one antibody that, if present, can determine a faster rate of progression to clinical type 1 diabetes. There's been work trying to determine the best times to screen people for type 1 diabetes based on taking into account we want to identify as many people as possible, but we also want to be aware of the public health needs and the reduced cost. So if cost is an issue, then screening at ages 2, 6, and 10 would provide the best sensitivity for picking up patients through adolescence who would develop type 1 diabetes. Practically, screening in buckets around these ages would likely yield similar sensitivities in picking up people who would progress to type 1 diabetes. If patients want to know their risk for type 1 diabetes, or if we as healthcare providers want to help them assess their risk for type 1 diabetes, there is only one set of markers in the blood that can be used to determine if they will develop type 1 diabetes. And these are type 1 diabetes autoantibodies or islet autoantibodies. There are 4 main islet autoantibodies as discussed earlier, and those are antibodies to GAD, IA2, insulin, and zinc transporter 8. Again, all 4 of these are available commercially, but there are also many research labs that measure these antibodies, as well as several screening programs available in the United States where you can get these antibodies measured for free. So in cases where measuring antibodies is a challenge, using a screening program like TrialNet, who screens family members who have type 1 diabetes, or ASK, who is a general population screening study, are very good options to be able to get this information. In certain areas of the country, such as the Dakotas, Sanford Health patients can get screened through Pledge, or in Washington State, patients can get screened through Cascade. So if you live anywhere in the United States and commercial antibodies are hard to order or are not available due to logistical reasons, using a screening program is a great option.
Managing screening-related anxiety. Data shows that greater than 70% of caregivers of autoantibody positive children in the general population reported high anxiety about their child's type 1 diabetes risk. 45 to 70% of autoantibody positive 10 to 15-year-olds reported high anxiety about developing type 1 diabetes. So both caregivers and patients have reported high anxieties about these screenings. The best response is addressing the anxiety. It is both ethical. Not addressing is associated with lack of follow-up and avoidance. Ask simple follow-up questions. How are you feeling about this information? How are you doing? Have a low threshold for referral to a behavioral health provider.
Jessica, let's start and talk a little bit about if Jack and his parents come in, what we can discuss with them regarding the benefits of screening for type 1 diabetes.
The conversation that I would have with Jack and his parents would discuss that screening for type 1 diabetes would help to lower the risk of Jack being hospitalized for diabetic ketoacidosis. We would also discuss that we could potentially get him involved in clinical research studies, and that we do have some therapies out there that could potentially prolong the clinical diagnosis of type 1 diabetes.
Right. And I think it's so important to focus on the DKA or the diabetic ketoacidosis. I think a lot of families that don't have anybody in their family with type 1 diabetes, especially, don't understand how sick kids can be when they present in DKA or diabetic ketoacidosis. And nationally, there are very high rates of DKA. Here in Colorado, we have almost 60% of our new onset kids present in DKA. So really explaining to Jack and his family what that looks like, that it looks like an admission to the pediatric intensive care unit, that patients and families are usually under a lot of distress, that having DKA is not good for your body and puts you at risk for short-term and long-term damage. I think those are all things that are really important to explain to families, because we know that with regular follow-up, we can at least reduce the risk of DKA. What else do you think the family should be told if they're told the benefits and they're still concerned about screening because they just don't want to know the information?
That's where we would discuss the potential for the benefits of being screened, so that if we would know what his risks were, that we would be able to potentially hold off the disease, and by doing clinical trials, and also by we have some immunotherapies that we can start using.
Right. And I think that when we're talking about the potential benefits, we can't ever oversell, but we also can't undersell the opportunity of having time without diabetes, especially during childhood when you're going through so many changes. And if you can get through a time in your life where you're changing schools or you're going through puberty, that can make a huge impact on your life.
I agree. And I also want to stress that the mental health part of it is really important too. Having a chronic disease can really cause an increased amount of depression in these kids. And so as long as we can keep them both physically and mentally happy, I think that that is a really important part to all of this.
Yes, absolutely. And I think also along with screening, we'll identify people who actually need behavioral health support sooner. And so hopefully by providing people with what they need both physically and mentally sooner, it will help them when they eventually do need to take insulin or another treatment.
Absolutely. And how would you address cost and access, Dr. Simmons?
So the antibodies to screen for type 1 diabetes have all been available commercially since 2017. But even being able to order them from the commercial labs doesn't mean that they're necessarily always covered, or that there aren't implications for providers who order those tests based on performance metrics at their individual clinics or institutions. So when we're talking about cost, we really have to think right now about what is the best way if someone is at risk for type 1 diabetes because, for example, they have a family member or they want to be screened, to be able to ensure that they have this testing done and that it's at a low cost. And in the current state, that would be through a research program where autoantibodies are tested for free. And the research programs that do that nationally are TrialNet, that screens relatives of people with type 1 diabetes for islet autoantibodies. and then ASK, or the Autoimmunity Screening for Kids program, that screens for all 4 biochemical antibodies that we talked about earlier, as well as celiac disease. And the benefit of these programs is that they're no cost, and that the people who are involved with these programs have been doing screening and following antibody-positive patients for a long time. And so patients and healthcare providers can get support. So in the current system, anyone can order a commercial test. And if that's what a patient wants because they're getting other blood draws, it's the easiest for the office because you can do it there without having to ask the family to leave the office and do something else, then it absolutely should be done. But we're still in an era where we're working on advocating for cheaper and more widely accessible testing for people with all insurance plans. In our case, Jack's family learned that although most children diagnosed with type 1 diabetes do not have a family history, his risk for type 1 diabetes is higher because he has a family member with type 1 diabetes. Therefore, the family decided to screen Jack for type 1 diabetes. And so the 4 type 1 diabetes autoantibodies were measured in a laboratory. Jack tested positive for multiple of these autoantibodies. Specifically, he tested positive for GAD antibody and zinc transporter 8 antibody. What are the next steps when a patient tests positive for multiple type 1 diabetes autoantibodies? After screening positive for type 1 diabetes, the most important next step is to make sure that the patient does not have type 1 diabetes at that time. In order to rule out clinical onset of type 1 diabetes, a healthcare provider needs to assess the patient for symptoms of diabetes and also check a glucose level, either in the blood or in the urine. If possible, it's helpful to have a hemoglobin A1C to show what glycemic status has been over the last 2 to 3 months. And after all of these things have been done to make sure that the patient is safe, it is also very important to confirm the islet autoantibody status of the patient. This should be done by measuring antibodies again in a CLIA and CAP certified lab, and preferably at a different lab from where the screening occurred if there is any question about the results.
Important messages to share when discussing screening. Type 1 diabetes can be identified before clinical symptoms develop. People with a family history of type 1 diabetes or other autoimmune diseases have an increased risk for type 1 diabetes development. Screening for type 1 diabetes should occur at multiple time points throughout childhood. A negative result does not mean that someone will never develop type 1 diabetes. Screening for type 1 diabetes is commercially available and is completed by measuring type 1 diabetes-related autoantibodies in the blood. In the next section, we will discuss a change of course utilizing immunotherapies to delay the onset of type 1 diabetes. So next steps after screening, Jack, a 9-year-old, was offered screening for type 1 diabetes during an annual physical, and his parents consented. He tested positive for multiple autoantibodies. His primary care provider assessed for symptoms, checked a blood glucose level, and ordered a hemoglobin A1C. Jack's primary care provider consulted with a pediatric endocrinologist. Follow-up metabolic tests were performed to stage type 1 diabetes.
Jack has tested positive for multiple type 1 diabetes autoantibodies. Metabolic test results are as follows: hemoglobin A1C 5.6%, fasting glucose of 90, 2-hour oral glucose tolerance test glucose of 185, and a continuous glucose monitor time above 140 of 19%. In November of 2022, the FDA approved teplizumab as the first treatment to delay the onset of clinical type 1 diabetes. This medication was approved in patients age 8 and older and is given through an IV infusion once daily for 14 days. Each day is a 30-minute infusion followed by a period of observation to make sure that the patient is tolerating the infusion well. Teplizumab is an anti-CD3 monoclonal antibody that may work by changing the phenotype of activated T cells. So what that means is that a monoclonal antibody binds to one protein. In this case, it binds to the epsilon chain of the T cell receptor. And after it binds, the T cell looks exhausted. So beforehand, there are markers on the surface that show that the T cell is activated. And after treatment, there are markers that show the T cell is exhausted. The study that led to the approval of teplizumab is called TN10. This is a TrialNet study, and it was the 10th study through TrialNet, hence the name TN10. And in this study, teplizumab delayed the diagnosis of stage 3 type 1 diabetes by a median time of 24 months. The graph on the right, you can see that the teplizumab-treated patients are in blue, and the patients receiving placebo are in red. And you can see that immediately after administration, there's a separation in the amount of people receiving drug versus those receiving placebo that had onset of type 1 diabetes. When you look at the time point where half of the patients were diagnosed with type 1 diabetes, in the placebo group, it was around 24 months. And if you look at the time point for the teplizumab-treated group of when half developed type 1 diabetes, it was 48 months. And that is where there is a 2-year difference in the treated group versus the placebo group. Another way of thinking about this scientifically is that the hazard ratio for type 1 diabetes diagnosis with teplizumab versus placebo was 0.41, meaning that patients who received the medication had a lower risk of developing type 1 diabetes. There were 76 high-risk individuals who participated in this study. 55 of them were under the age of 18. So it's important to remember that although this study enrolled patients up to age 45 and treated a patient at age 49, that the majority were younger. A subsequent analysis of the TN10 patients showed that the delay from stage 2 to stage 3 type 1 diabetes was even longer than the original 24 months. In this follow-up paper, you can see that the red group who was treated with teplizumab and then the black line or the black group that was treated with placebo, there is a difference of 32.5 months, so nearly 3 years. Continuing to follow this group over time will let us know if this delay persists longer. When we are giving a patient teplizumab, we need to make sure that they do not have any evidence of an active infection, because we want to make sure that while their immune system is undergoing immunomodulation, that they are not at risk for an infection. In order to do that, we take a very careful clinical history. We include in that clinical history a vaccination history and make sure that all the vaccinations are up to date per the CDC guidelines. We do laboratory tests to exclude infections that may not always show up symptomatically. We check for Epstein-Barr virus, cytomegalovirus, hepatitis C, hepatitis B, HIV, tuberculosis, and COVID. Some of these tests are going to vary depending on location for what you use to screen for tuberculosis. In areas where the incidence is very low, you may be able to ask questions. In other areas, you may do a PPD or a quantiferin test. And COVID can be tested by either antigen or PCR depending on what is best at your local institution. In addition to checking for viral infections, we want to make sure that patients are meeting the baseline blood counts and liver enzyme numbers that they need to be safe for infusion. Because the drug works by affecting the lymphocytes or the T cells, we know that they will go down over time. So we want to make sure that they start off in a safe place and that their lymphocyte count is not less than 1,000. In addition, because we know this medication can cause an increase in liver enzymes or in bilirubin, we want to make sure that when patients start this medication, that they do not have an elevation that is more than 2 times normal for their liver enzymes or 1.5 times normal for their bilirubin.
Dr. Simmons, what treatment options does Jack have?
Well, now we know that Jack has stage 2 type 1 diabetes, so we can have an informed conversation with the family and talk to them about what the options are. I think the simplest option is to follow Jack in clinic and make sure that his glucose is being monitored over time, or his risk for progression to clinical type 1 diabetes is being monitored over time. And there are ways to do that. But what's exciting is that there are now other options, including clinical research trials and also an FDA-approved treatment to give patients 8 and older and early type 1 diabetes stage 2. So for Jack, we can have a conversation about whether he wants to just be monitored and therefore hopefully prevent DKA, whether he wants to have the early treatment with teplizumab, or whether he would like to talk to a clinical trial team to discover what research opportunities are available. Are there any other options that you can think of, Jessica?
Those are all the options that I can think of. But are there benefits and risks to some of those treatments?
There are definitely benefits and risks. I think that when we're discussing a medication, the benefits and risks are outlined a little bit more, and I'm happy to talk about those in a minute. But do you want to touch on the benefits and risks of just following Jack in clinic?
Absolutely. So I think the biggest benefit, right, would be to avoid DKA at diagnosis. That is the biggest risk for Jack if it goes unrecognized and not screened, and we don't know that that is something that could be a risk that he has coming up. But making sure that the family knows signs and symptoms and checking and monitoring blood sugars.
With the medication, the obvious benefit is that some people are going to have a delay in progression to type 1 diabetes, and that the time without diabetes is very valuable from both a metabolic health standpoint and also from potentially a quality of life and burden standpoint. So the benefits are very exciting to talk about because we haven't had an option of any other treatment to talk about yet until now. It's really important, though, to talk about the risks associated with giving teplizumab treatment as well, which include side effects of the medication as well as time off work or school that it takes to receive the medication. And those are important factors to consider, along with the family really understanding if the child or the patient who's going to be treated is similar to the patient who is in the research study and what the differences are so that they can try to determine how much they are like the research participants where there was a delay in progression to type 1 diabetes. In your experience infusing patients with teplizumab, what are some things that you think either the patient or the family would have liked to know that they didn't hear about before the infusion or we forgot to tell them about?
So I think it's important to understand the time commitment for the infusion, because if we say it's a 30-minute infusion, there's also an hour of labs, an hour of vital signs and labs that we do that can be very much more of a time commitment than just 30 minutes. So I want to make sure that they understand how much time they will be here in the clinic doing the infusion. And also to understand that, we usually like to place a PICC line because doing 14 days of just a peripheral IV can be really tough on them. So those are the things that I would probably make sure that the family understood.
I think that's really interesting that you point out the PICC line because I think there are many things that patients have to do in preparation for infusion, even that take time. They have to make sure that all their vaccines are up to date. They have to make sure that they don't have an active viral infection. So they have to get safety labs before infusion. They have to be taking infection precautions to make sure that they can start the infusion safely. So it is a commitment for the family when they're trying to figure out when all of this will fit into their lives.
And the time commitment after, because they're going to need to do some follow-up labs and they're going to be careful with masking up and safety precautions in terms of infection risks. But how would you address cost and access to the drug?
I think that's really interesting. I think that we've seen in our experience thus far that patients that have commercial insurances are actually covered quite well under those plans. And the company at this time has a patient assistance program that can help with copays. And so a lot of privately insured patients can get this medication from a financial perspective with very little burden. I think what I'm most concerned about are patients with government insurance and what that access looks like to them. There is a program the company also has for out-of-pocket expenses if a patient is paying out of pocket, but government insured patients aren't private insured and they aren't paying out of pocket. And so I think that's where we really need a lot of advocacy.
Those are great points. And what are the side effects that we should be aware of?
I think when you're talking about side effects with families, it's really important for them to know what to expect. And if families know what to expect, then they don't seem as serious. The most serious side effects that we watch for severe cytokine release syndrome or potentially a hypersensitivity reaction to the medication. So those are the side effects that I always make sure to counsel patients on, although they're the ones that are also fairly rare. The side effects that patients are actually going to experience most commonly are a decrease in blood cell count, which they will physically notice, but we can share with them on their labs to reinforce why they need to make sure that they take standard infection precautions. And then the next most common side effect is to have a rash that is itchy or to have a headache. If a child or an adult is going to get more sick and have mild cytokine release, usually that happens about the time that the dose is fully ramping up and for the next few days after that. So a lot of times that's kind of over that first weekend if you're starting early in the week. And so I always make sure to prepare patients for that they may feel like they have the flu, they may be very nauseous, they need to make sure to drink water and stay hydrated as best as possible. And when families have this information ahead of time and know what medications they can use to treat their symptoms, they tolerate it very well.
After discussion with his endocrinologist, Jack's family feels that he would benefit from a delay in starting insulin and keeping his hemoglobin A1C lower for longer. Jack and his parents decided that he would take teplizumab to delay onset of type 1 diabetes.
A, no follow-up is needed is incorrect. Any patient in an early stage of type 1 diabetes needs to be followed so that they do not present in DKA at onset. B, regular clinic appointments with a healthcare provider trained in early type 1 diabetes management is correct. C, hemoglobin A1C, oral glucose tolerance test, or continuous glucose monitoring at regular intervals is correct, as patients need to have some way of monitoring their progression of type 1 diabetes. D, intermittent blood glucose checks and symptom monitoring is correct. This is one way of ensuring that patients remain medically safe when they have an early stage of type 1 diabetes. E, C-peptide measurement is incorrect, as this is currently not the standard of care. As we know, the development of type 1 diabetes is an autoimmune process. And so when we're thinking about potential therapeutic targets for modifying type 1 diabetes, we can look at different immune cell subsets and see how we can either block cells that are going to cause damage or encourage cells that are going to help regulate the immune process and prevent beta cells from being destroyed. So if we start in the middle, looking at the autoimmune process, at the center of it all is the T cell, because the T cell is what turns into the effector cell that gets activated and causes beta cell damage and leads to beta cell death and eventual type 1 diabetes. So there are therapies that can inhibit T cell activation. One of them we have talked about a little bit today, the anti-CD3 monoclonal antibody. If we're working outside of the T cell, we can also shut down the communication from the cells that give the message to the T cells, such as the B cells, by causing them not to be able to signal as easily. So any of these antigen-presenting cells could potentially be blocked and not allow the message to get to the T cell and therefore not start the autoimmune process. And then if the autoimmune process is already started, we can also work further along down the pathway where the cytokines are and provide medications that can decrease the effect of these cytokines and decrease inflammation and their effect on T cells. When we're looking at other ways that we can potentially impact the immune system in a positive way, it would be to actually encourage the development of the T regulatory cells. Or there are therapies that are working on regenerating beta cells. So if you can put more insulin-producing cells back and you can figure out a way to block the autoimmune process, that really would be helpful for people that already have type 1 diabetes. There are other therapies that are being studied to impact the natural history of type 1 diabetes, starting on the left with low-dose antithymocyte globulin, or STOP T1D. This is a TrialNet study in patients who are in stage 2 of type 1 diabetes, ages 12 to 34 years, who have presence of islet autoimmunity and a high risk of progression from stage 2 to stage 3 based on metabolic markers. After receiving ATG, or antithymocyte globulin, these patients will be followed to see how long it takes to develop stage 3 type 1 diabetes, looking at an endpoint of median time to diagnosis similar to the teplizumab data that we looked at earlier. The other 3 treatments on this slide are all treatments that are being studied in patients with new onset type 1 diabetes, so stage 3 type 1 diabetes. The first is rituximab, followed by abatacept, so an inducing agent followed by a maintenance agent. This is another TrialNet study in patients ages 8 to 45 who have evidence of islet autoimmunity. PROTECT is a study that was completed in patients age 8 to 17 with type 1 diabetes within 6 weeks and evidence of islet autoimmunity. And Verapamil is a study that was also completed in patients 7 to 17 with new onset type 1 diabetes within 21 days of diagnosis and evidence of islet autoimmunity. As is common in all new onset trials, the primary endpoints are to look at how much insulin the body makes, or C-peptide is made, in response to a mixed meal at the 2-hour time point. This trial was completed in patients with new onset type 1 diabetes within 21 days of diagnosis.
What is it important for families to know? Teplizumab was approved for stage 2 diabetes to delay progression to stage 3 diabetes by an average of nearly 3 years. Teplizumab is a 14-day IV infusion given daily, and other therapies are in development. Jack has tested positive for multiple type 1 diabetes autoantibodies. Metabolic test results are as follows. Hemoglobin A1C is 5.6%. Fasting glucose is 90. 2-hour oral glucose tolerance test is 185. And continuous glucose monitor time above 140 is 19%. Keeping an eye on the horizon, monitoring patients on type 1 diabetes immunotherapies. Jack is a 9-year-old boy with stage 2 type 1 diabetes who has completed 14 days of teplizumab treatment. What is next for him?
A, no follow-up is needed, is incorrect, as patients who receive immunotherapy still need to be followed for the development of clinical type 1 diabetes. B, regular clinic appointments with a subspecialist is true. Patients need to be followed for progression of their type 1 diabetes and receive education and metabolic monitoring at repeated intervals. C, blood glucose and symptom monitoring is true. Blood glucose monitoring and symptom monitoring will keep patients safe and reduce the risk of them presenting with DKA at clinical onset. D, EKG monitoring is incorrect, as this is not indicated in early stage type 1 diabetes or after teplizumab treatment. E, hemoglobin A1C is true, as this is one of the methods that can be used to metabolically monitor a patient for progression of type 1 diabetes.
The most common adverse effects of teplizumab are lymphopenia, rash, leukopenia, and headache. A small percentage of patients can have cytokine release syndrome. This includes fever, fatigue, muscle and joint pain, nausea, headache, and increased liver enzymes. 5 days after completing infusion with teplizumab, Jack developed lymphopenia. Dr. Simmons, how would you respond to this?
Lymphopenia is one of the most common side effects that you see with teplizumab administration, so I would not do anything to acutely respond to that. I think it's good information to have. You want to track what the lymphocyte count is and make sure that it is recovering as expected over time. But the only thing that I would do is use it as an opportunity to counsel the patient in making sure that they're taking appropriate infection precautions at that time, knowing that their immune system isn't working at its full force. I think that there are other complications that you see with teplizumab where it does require a more immediate response and trained staff on site. Jessica, what are some of those things that you've seen that require trained staff and providers?
One thing we worry about is low blood pressure. We have seen that, or a widening pulse pressure. We've also seen fever. That's something that needs to be addressed fairly quickly.
Yes, and I think fever in the context of a lot of these patients having a central line, you need to have someone who's really comfortable evaluating and determining whether this is an expected side effect as part of a cytokine release, or if it's a potential line infection or an other type of infection that needs further workup. And so communication is really important. And so when something happens to a patient and you're concerned, if you're the one giving an infusion, how do you ensure appropriate communication and care of that patient?
Well, there's two parts to that question. Appropriate care and communication to the patient, making sure that you're discussing the results of the labs, making sure that they are following the correct precautions, but also having good communication with the provider that you're doing the infusion with. So making sure that they understand all of the symptoms, the vital signs, and relaying test results to them. Anything I missed, Dr. Simmons?
No, I think that's right. And I think it just is very helpful to have conversations before infusions or work with people often so that you know how to communicate with each other and you know what is important and not important, so that if something happens and you have to make a decision quickly, it can be done in an appropriate time frame. Once a patient is in stage 2 type 1 diabetes, how do they need to be followed until they reach stage 3 type 1 diabetes? The goals of following them are really twofold. One is to make sure they remain safe, and the other one is to detect their progression. In order to make sure that patients remain safe, you want to make sure that they are aware of the symptoms to watch out for, the most common symptom being frequent urination at night at the very beginning. And also, you need to make sure that they have a way of testing their blood glucose if they are ill or concerned that they may have symptoms and have high blood glucose levels. In order to detect progression, hemoglobin A1C, blood glucose measurements, continuous glucose monitors, and oral glucose tolerance tests can all be used. When we've looked at data showing which test is most accepted by patients, patients are most likely to do hemoglobin A1Cs and blood glucose monitoring and least likely to complete oral glucose tolerance tests. However, in the setting of needing a treatment or wanting to enroll in a clinical trial, oral glucose tolerance tests remain a gold standard.
Getting back to our case study, Jack had lymphopenia that had resolved by the end of the infusion, but his lymphocyte count was not back to baseline. Labs at 1 month post-infusion showed complete normalization of his lymphocyte levels. Jack is seen in clinic every 6 months with intermittent CGM wear every 3 months, and family has agreed to OGTTs and hemoglobin A1C at each visit to determine if he responded to the treatment. Jack has a blood glucose monitor and checks his glucose if the family is concerned for diabetes symptoms or when he is ill.
When a patient is treated with teplizumab, what are the most important things for both clinicians and families to know? The most common side effects seen with teplizumab administration are lymphopenia, rash, leukopenia, and headache. Tools used for determining progression of type 1 diabetes, whether a patient receives treatment or not, include hemoglobin A1C, continuous glucose monitoring, oral glucose tolerance tests, and blood glucose monitoring. A patient's metabolic status should be evaluated at least every 6 months in childhood and adolescence. And finally, patients and caregivers should know the signs and symptoms of type 1 diabetes and should always check blood glucose levels if the person is experiencing symptoms or when they are ill. Let's recap what we learned. Type 1 diabetes begins long before clinical symptoms manifest. Screening for type 1 diabetes can identify people at risk, and screening can be completed by measuring type 1 diabetes or islet autoantibodies through several screening programs that are available in the United States or in a commercial laboratory. Addressing screening-related anxiety in patients and family is important, and teplizumab is a treatment that is approved to delay the onset of stage 3 type 1 diabetes in patients who have stage 2 type 1 diabetes and are aged 8 and older. Educating patients and caregivers carefully about the benefits, risks, and the monitoring requirements for teplizumab is important before initiating treatment, and monitoring patients after immunotherapy for resolution of any side effects and for progression to stage 3 type 1 diabetes remains very important.
Thank you for joining us for this education. Don't forget to complete the evaluation and claim credit. We appreciate you taking the time to learn more about this subject with us.